Neonatal herpes is fortunately a rare condition. That said, it's oftentimes on the differential diagnosis as babies under a month of age come in with fever or come in with skin lesions, vesicles, and so forth. So it's critically important that people think about neonatal herpes and have an understanding of how it can present so that they hopefully recognize a baby with neonatal herpes earlier in the course and then can embark on the workup, the evaluation, the diagnostic approach, and starting antiviral therapy, which can have an impact on the long-term outcomes from the infection. At our freestanding children's hospital in Birmingham, we have about 280 beds or so. Each year, we may see 1 or 2 babies with neonatal herpes. At the same time, we have 250 babies admitted for rule-out sepsis. So it gives you a sense for how uncommon it is. And you can go for a number of years without actually seeing neonatal herpes, unless you're sort of where I am in infectious diseases, where we might get pulled in for each case. But if you're just sort of on the wards or certainly in a private practice office, you may go for long periods of time without seeing it. That said, again, it's really important to be aware of it so that when you do have a baby with neonatal herpes, you can draw back on that experience of what you've known already and be able to figure out how to approach that baby, how to diagnose it, how to start antiviral therapy, what antiviral medications to use, and how to move forward from there. The issue of vaccine denial, vaccine refusers, vaccine questioners is something that pediatricians are aware of on a daily basis. People that are in private practice, they deal with it literally every single day. If we back up 100 years, 16 out of every 100 babies born died of an infectious disease by the time they were 5 years of age. There's 4 million children born each year in the United States. That's the equivalent of 640,000 of them dying before they were 5 every year, every birth cohort. We have a way to prevent that. We have vaccines that are safe and effective, and we need to be passionate in our advocacy for vaccines. By being passionate in our advocacy for vaccines, we are directly saving children's lives. With the 2009 Red Book, the report of the Committee on Infectious Diseases from the American Academy of Pediatrics, there were some modifications in the recommendations of who should receive palivizumab or Synagis, the monoclonal antibody that can prevent hospitalizations from respiratory syncytial virus or RSV infections in young babies. When the Red Book Committee was looking at how to modify those recommendations, we went back to the evidence. We went back to the literature and what we know and what we don't know about who is at highest risk of RSV infection. And for that very large group of babies who are 32 to 35 weeks gestational age, what we know is that their highest risk period is during the first 90 days of life. So we modified the recommendations accordingly. This is a very expensive product. 1 dose of palivizumab costs as much as an entire 18 years worth of vaccines for a patient, for a child. So it's something that we've got to weigh in on. Another point that I think is very important that people sometimes don't remember is that palivizumab has never been shown to change outcomes, to change mortality rates, or anything. It prevents hospitalization. It does it in a modest way. But it is not a way to save every baby from RSV. And so we need to be smart in the way that we apply this resource and this medicine to try to target those babies that are at highest risk.